Bismillahirrahmanirrahim. Dear students, Assalamu alaikum. So our today's topic of discussion is another condition which is involving the bursies. And this time, this condition that is involving the bursie, so that bursie is called supraspinous bursies. Mean the bursie which is present at the above the level of these spines of the second and fifth thoracic vertebrae. So here you can see in this picture. So this area that is called the wither area or the point of wither. So this is the highest part of the body of horse. And this area is covered by the thoracic vertebrae, mean from second to fifth thoracic vertebrae, the spines of these thoracic vertebrae, they are present here. So to provide the cushion of the, you know that these spines, they are the, you know, the sharp bones, and they can damage the skin and above lying structures, softer structures. So the nature has provided a cushion in the form of the bursae here, and this bursae which is present above the level of these spines. So say this is a spine, this is a spine of, so above the spine, the bursae that is present, so this is called supraspinous bursae. And this the inflammation of this supraspinous bursae, so this condition may lead to develop, so this inflammation may lead to develop this condition. So this condition is called fistulous wither. So this is again a very highly problematic condition like the pole level. So this type of bursitis, that is also very much problematic, because this simple inflammation after it get infected, so it may result into development of fistula. So that's why this condition is called fistulous wither, mean the presence of fistula at the point of the wither. And in fact, this fistula is the leading tunnel from the skin into this bursae. So that's why this is called fistulous wither. And this is a very, again, very problematic condition. And because of the deep tunnel, and because of the high contamination, and because of the bigger abscess formation, so sometime the owner that is very much worried, and even it is a very much highly problematic to the animal as well. So the common cause of this problem is initially it is the skin infection, and usually the skin infection, the infected is involved, that is the brucella again, like in the cases of the pole level. So here the brucella abortus that has been isolated from these infections or from these fistulous withers. So similarly, the other associated conditions may be the sweating, it may be the ill fitting of the saddle, and sometimes the saddle that has been not fitted well, and uh, the the most cranial part of the saddle, it strikes over that area and it lead to injury or trauma formation, and ultimately this trauma may lead to development of the fistula. Similarly, the bad conformation of the animal, the conformation of the forelimb, if it is not the animal that is not properly fed, or it is not having a very good conformation or very good health condition. So that's why these weaker animals, they are usually more susceptible for the development of this sort of issues. So this condition is called fistulous wither, and it is, in fact, it is the bursitis of this area, and the bursae that is present, that is called supraspinous bursae, and this condition is called the bursitis of the supraspinous bursae. And this condition is very much common in horses, and usually the horses, the etiology behind this condition is the weakness of the animal. They have not the bad conformation, and the trauma due to ill fitting of the saddle, and separation may extend to the neighboring tissues, and it may result to fistula formation. So the brucella that has been isolated from this condition, and it is the main causative or infected agent that has been isolated from the cases of the fistulous wither. So as far as the treatment of this condition is concerned, so this sort of condition needs the extensive surgery. So we have to remove all the necrotic material, and we have to remove all the fistulated necrotic material from the side. So after giving an extensive incision, so because we have to wide open this lesion, this fistula, and we have to go inside deeply, so that what sort of necrotic material we find, it should be curated, it should be removed, and it should be flushed. And it's a long-term therapy, because these deep tunnels, deep fistula, so it takes a long time to complete recovered, to completely filled with the healthy tissues or granulating materials. So that's why an extensive surgery is required to remove the contents, to remove the pus, to remove the necrotic material, and we have to go deeper inside, up until to the that point of the bursae, where the infection that is still present, and this condition is treated as an open wound. So we have to first cull out the causative agent, or the instigating cause, like if it is because of the saddle, that the use of the saddle that should be discontinued. We have to enlarge the opening of the fistula and sinus, so that we should be very much facilitated, that we can drain the contents. And we have to remove the necrotic materials after having a curating surgery inside. So if you look at the anatomy, this picture showing the anatomy of showing the muscular positions of the forelimb and the hind limb. So you can see the different types of the muscles and tendons they are present. I mean, mostly we can divide these muscles into two categories: the muscle which are tendon which are responsible for flexion, so these are called flexor muscle or tendon, and the tendon or muscle which are responsible for extension of the limb, so that these are called. So if you look at the most caudal aspect, so this area is contributed by muscles and tendons which are called the flexor muscles, and it starts from superficial digital flexor tendon, and inside to this is the deep digital flexor tendon. And similarly, we have a very important common. So this is the common flexor tendon, and this one is the lateral digital flexor tendon, which has been operated during your experimental surgery. And similarly, we have some suspensory ligaments. So these are the ligaments which are responsible for giving a support and external support or suspension, for the suspension of these muscles and tendons. Similarly, these are called the suspensory ligaments, and behind to this is a very small ligament that is called the annular ligament. So this is also very supportive structures which can hold the tendon and muscles in positions. So this area, this joint that is called the Fetlock Giant, and this is mostly contributed by, in case of forelimb, this joint is made up of the terminal part of the radius and ulna, and then the terminal part of the third metacarpal bone, and then this in the first phalanx, between the third metacarpal bone and the first phalanx. So here it is the third metatarsal bone and the first phalanx. So this is called the Fetlock Giant. And behind to these two bones, the carpal, the third metacarpal and the first phalanx. So there are two small bones. So these are called proximal sesamoid bones. Proximal sesamoid. So these sesamoid bones, along these two sesamoid bones, the tendon sheath or the tendon of the superficial or deep flexor tendon, they are passing. So in fact, the purpose of this picture was just to refresh your knowledge or anatomical knowledge about the different muscle tendon which are present in the forelimb or in the hind limb. So sometimes these muscles, these tendons and their tendon sheath, they are affected with certain conditions, and ultimately these conditions may result into disturbance of the normal movement and locomotion of the animal. Condition that is called wind gall. This is also a very common condition in equine, and in fact, this condition is because of the inflammation or because of the infection of the because of the infection of the tendon sheath, so of the flexor tendon, which are present at the level of the fetlock joint. So this is the fetlock joint, and I have already told you that these are the two small bones which are called the proximal sesamoid bones, and along these bones you can see the these the flexor tendon they are passing, and these tendons, they are superficially, they are covered with the sheath, and these sheaths, they are also secretory in nature, in which the tendons they are present, the tendon fibers they are present, and ultimately they also you know that these sheaths, they secretes the secretory material, and ultimately during the movement they reduces the friction of the tendon with other neighboring structures. So that's why these tendons, mostly the tendons, they are also contributed by tendon sheaths which are secretory in nature, and also they keep the tendon in position, and ultimately these tendons, they remain avoided from the frictions with the other bones. So say there is a high chance of friction of tendon with these two bones. So ultimately the tendon sheath that is lying, that will save the tendon from the friction effect of these bones, because this sheath is secretory in nature. So what happens that in case of wind gall, so because of the friction or increase or high pressure of friction, so these tendon sheath, they get inflamed, and ultimately they become overfilled with the fluid. So this sort of condition is developed. So this condition is called wind gall, and you will see at the caudal aspect of the fetlock, you will see a small fluid filled accumulation, and this fluid full accumulation, in fact, this is the over secretion of the tendon sheath at the point of the fetlock. So this condition is called wind gall. So I can uh, define this term. Wind gall is the fluid filled swelling of the digital flexor tendon sheath, and it is usually seen behind the fetlock joint. So these are the in fact, the pathophysiological aspect as well as the definition of this condition, wind gall. So you can see these sort of cases very common in equines, the cases of wind gall. So sometimes this condition is inherited. I mean, it is continued from generation to generation. I mean, some genetic involvement is there, and you will see that when you get the history from the owners, they will tell you that the father of this animal that was also affected with this condition, or some other generation, they were also affected with this condition. So this is a painless condition, but it is, sometimes the owner that will never want it is this sort of swelling that should be present at this region. So in fact, this swelling, if you observe, it is because of the overfilled, over secretion of the tendon sheath, and that fluid that get accumulated at this area, that is the posterior aspect of the fetlock joint. And this is equally present in the forelimb as well as in the hind limb. And usually uh, I mean, this sesamoid bones, they have their own sheath, and when this fluid is filled, so this sheath that is also become distended. So you will see the extension of the great sesamoid sheath because of the over secretion of the fluid, or because of the because of the overfilling of the or fluid over that side. So it is a very softer fluctuating swelling, and it is painless most of the time, until and unless and because of the wrong approach of the owner, or because of the wrong approach of some quacks that they usually what they do, they try to remove the fluid or aspirate the fluid by inserting a very dirty needle inside. So that's why this sterile fluid sometime it get infected, and this only this fluid filled area it result into abscess formation. So this is the time where now you are making more complication or pouring more complication inside. So that's why this fluid filled cavity now it has been shifted to infected abscess. So this is a very then this condition is it is now more aggravated and now more complicated, and it may further affect the normal movement of this joint because of this infection inside. So the treatment is quite clear that the rest is the best treatment, and you have to place the compression bandage just to reduce the space for the accumulation of the fluid, and you have to place the animal for a rest of 3 to 4 weeks, so that this condition may be subsided, and you can offer the massage so that the fluid that has been accumulated that can be released or that can be disseminated all around, and less space should be available, and the frictions that should be and the owner of the animal that should be advised that he must put the animal in a position before he is going to apply the harsh exercise. So that's why this is also noted in some cases when the animal they are put suddenly on the work or heavy work. So because of that overstretching of the tendon, so this tendon sheath it get inflamed, and ultimately it become over secreted, and ultimately it become fluid filled. So that's why you will see the presence of wind gall over that area. So here you can see this is the real time picture. This is the real time picture. This is the Fetlock Giant, and you can see above the level and posterior aspect of the fetlock this tendon sheath that is coming, and at that area that tendon sheath is inflamed, and ultimately it has resulted to fluid filled accumulation. So this is called wind gall. Tharopin is also a quite similar condition with the wind gall, and in fact this time this inflammation of the tendon sheath that is present at the level of the hock joint and above the level of the hock joint. Say this is the hock joint, this is the point of the hock, and you will see this type of inflammation that may be present at the lateral as well as the medial aspect of the joint. So this condition is called Tharopin, and this is the in fact this condition is the Tenosynovitis, mean the inflammation of the tendon sheath along with the secretion of the fluid. So this is called Tenosynovitis, and this Tenosynovitis has resulted into accumulation of say so usually again these flexor tendon of the deep digital flexor tendon, this time the flexor tendon of the deep digital flexor tendon, they are inflamed, and this tendon sheath is inflamed, and ultimately it has resulted to accumulation of the fluid over that side. So at the level of the point of the hock, you will see at the lateral as well as at the medial aspect that you will see a fluid filled area, and that fluid is very much fluctuating, and it has been resulted because of the overuse of the hind limb and because of the stretching of the flexor tendon and their tendon sheath, and ultimately it has resulted into accumulation of the fluid because of the extra secretion of the fluid from the tendon sheath. So this is called the tenosynovitis, the inflammation of the tendon sheath resulting into fluid secretion of the deep flexor tendon at the of the hind limb, and you will see soft non-painful swelling just above the point of the hock. So this is the point of the hock, this is the point of the hock joint, and you will see the fluctuating swelling just above the point of the hock, and that swelling may be at the medial aspect, in the inside of the limb, and the lateral aspect of the hock joint. Again, in the cases, just like the cases of the wind gall, you will not see any sort of lameness until and unless you have made more aggravation or drastic changes inside because of the wrong or approach of the treating these conditions, and ultimately this wrong approach may result into infection or abscess formation. So this is another condition which is called radial nerve paralysis, and you know this radial nerve is also been noted, or this sort of problem that has also been observed in the field practice. So radial nerve, it is the biggest nerve of the the main nerve or biggest nerve of the brachial plexus, and radial nerve is the nerve after coming from the brachial plexus. So this is innervating to all the extensor muscle of the forelimb, extensor muscle of the forelimb. So the main objective of the extensor muscles. So these include the extensor carpi, radialis. Uh, there are other 2-3 important extensor muscles. So the important function of these extensor muscle is to cause the extension of the forelimb. So when this nerve is damaged, it may lead to paralysis of all the extensor muscles of the forelimb. So depending upon whether there is a complete damage of this nerve or some branches of the radial nerve they are involved. So if there is a complete damage of this nerve, it means we cannot expect the extension of that affected limb. So ultimately, when there is no extension, only flexion is there, it means there is an imbalance between the flexion and extension. So when there is no extension, it means there is a heavy flexion. When there is no extension, it means there is a heavy flexion, because now the situation is imbalanced. So that's why in these cases, when this nerve is damaged, so it will lead to paralysis of the extensor muscles and tendons, and it will lead to over functioning of the flexor muscles and tendons, and it will result into flexion of almost all the joints of the affected limb. So this is a very important clinical sign you will see in this condition, and ultimately because when there is a complete damage to the nerve, so no possible treatment and recovery is possible. So this is the largest nerve from the brachial plexus, and you can see in this picture, so this nerve, when it leaves from the plexus, it will pass downward, outward, along the musculoskeletal groove of the humerus bone. So along the musculoskeletal groove, you can see this musculoskeletal groove is meant for this particular nerve. So the nerve that is passing around, and it is innervating the different extensor muscles like the triceps muscle, the extensor carpi radialis muscle, and common extensor carpi muscles. So these are the very important muscles of the forelimb, and ultimately these muscles, they are responsible for causing the extension of the forelimb. So when there is a complete damage, ultimately these all the muscles, they get paralyzed, they become non-functional, and we cannot expect the extension of the limb. So when there is no extension, it means there is a hyperflexion. So this condition is more common in equines and less common in cattle and dogs as well. So the main etiology is because of the trauma. I mean, the trauma at the area where this nerve is protruding outside and along the side of the musculoskeletal groove of the humerus. So if there is a direct injury at that site, and similarly, while this condition is mostly observed because of during the time of the casting of equines. So during the time of the casting, so there is a high compression between the thoracic and the limb, the medial part of the limb and the thoracic cavity. So this compression, sometimes it can cause the extra pressure and cause the trauma to the this radial nerve. And similarly, sometimes if there is a damage to the first rib due to roadside accidental injury, the first rib is damaged, and this first rib, because of the trauma or because of its fracture, it can also lead to cutting of the radial nerve. So it will lead to cause the radial nerve paralysis. So these are the main important etiological factors because of the compression of the nerve or because of the overstretching of the nerve and because of the injury due to the fractured first rib. So this damage to the radial nerve can happen. So this is the very very clear cut presentation of the radial nerve paralysis. You can see in this picture if the radial nerve is paralyzed, it means the extensor muscles, they are paralyzed, and ultimately you will see different changes. All the joints of the forelimb now they are flexed because there is no extension, mean there is a overflexion. So this joint is flexed, this joint is flexed, and this joint is flexed. And similarly, when the triceps brachii muscles that is non-functional or that is paralyzed, because the triceps brachii muscles, this is the muscle which is responsible for holding the elbow joint in position. Okay, when this triceps brachii muscle is paralyzed, so you will see the elbow joint, it become dropped. Normally the elbow joint should be lying here. Now the elbow joint that is dropped down. So this condition is also called dropped elbow. So this is the very pathognomonic sign of the radial nerve paralysis. When you come across such cases in field, the main important sign would be the flexion of all joints in case of complete damage to the radial nerve, and the dropped elbow. The elbow joint, it will be more dropped down as compared to its normal position. So this is the phenomena that in case of complete paralysis, you will see the pictures like here. And in case of partial paralysis, it means that the further small branch of the nerve that is damaged, so it can has little damage as far as the flexion and extension is concerned, and it will result into dropped elbow because of the paralysis of the triceps muscle. So this is about these conditions. Thank you very much for patience listening.